And the first talk will be by Professor Kassim Javaid of the University of Oxford, updates on the RUDY study.
Oh, thank you, Mike. And recruitment, and then what we've learned over the last few years. So this is the RUDY platform. If you've never heard about it, it's patient-facing. You just Google rudystudy.org. It's basically delivered by University of Oxford, produced by patients, and this is the boring things you have to do for the ethics committee with the primary objectives. And it's really about understanding the impact of rare diseases on patients and their families' lives. And we have a whole list of disorders that we have here. You can see FD is not on there because I'm going to go into it in more detail. But I often get asked, why did we do it? Well, in 2012, the government said we want to improve rare disease research, and we're going to give money to each of the different specialties. And we had a question. Do we do one database for each rare bone disease? That's 456 databases. And then how do we pay the hospital coordinators to recruit the patients? And then how do we pay them to enter the data? Because there's no way the government was going to pay for that. So we said, well, most of the data is very weak. We don't know much about any of the rare diseases. So let's do something for all the rare diseases. And we're going to give up on recruiting from hospitals. It's too complicated. Let's just get people living with rare disease to enter their own data. And that's the rationale for it. And so we have people living with rare disease in their family. They do online consent, and the data is for research. It gives us more understanding. But very importantly, we wanted to build on the benefits for people taking part. Why would you give up half an hour of your time every 6 months to fill in a questionnaire? Really focus on that. It's a super small team, okay? So I'm half clinical, half research, and a little bit of my research time is spent doing RUDY. Alison is the brains. She runs the whole study, and that's her main job. And Nathaniel is the programmer, and he does all the programming. And that's it. Joe just gives some advice. So we're a super small team, which is great because we don't need much money to keep going. What we do have is a very clear governance structure. And so we have all these committees, but really it's the study delivery team at the bottom who do all the work, but it's the patient forum who tell us what to do. And the patient forum tell us how to recruit patients, they tell us what forms to use, they really give us feedback on what to do. And if you're a researcher, it's really easy to access the data. You go to the website, click on the researcher button, download the analysis template form, and then just email it to us. So what does it look like if you join RUDY? So you have these sort of general questionnaires, and then we also have disorder specific, and you have these sort of forms you can fill in. And with the FD community, we devised one for FD, so it's got bone, you can see all the things at the top, and then for each bone they click, you can fill in a little bit more information. But it also allows people to really feel valued, so they can put in other studies they're involved with. So we have a genome project, so if they're involved in a genome project or any other study, they can put it into RUDY, and what that means is that study can then use their RUDY data. So if you've got a weird study looking at, I don't know, biopsy study in the disease, if they're in RUDY, you can have all of their quality of life measures to go with the biopsy data. You have to collect it again. And then anytime we publish anything with your data, it goes on your web page as well. So there's an agreement that data then, so people can see how their data is being used. But the biggest thing came from our lawyers. They said, when you consent for a study, why should it be for life? They said it's not like a marriage. So we actually let people change their minds. How much you want to take part, how much you not want to take part. Do you want to fill in the questionnaires? What do you want to do with the data, and how do you use it? You can change your mind at any time, any place, if you log into your website. And what that meant was that everyone said yes. Because if they knew they could change their mind, they all said yes. We were really worried they'd all say no, and then we'd have a website that wouldn't do any research, but they all said yes, which is really good. And the main benefit is all the data they put in, they can look again. And sometimes that's been really helpful. So if they fill in a quality of life measure, they can then use that when they apply for benefits. And people have done that in the social system. It's also quite disheartening because you fill in the questionnaire, you think you're really good, you think, oh, maybe I do have a mental health problem. Maybe I do have this. And that we haven't really, people just deal with that by themselves. And then we've sort of built it. We really wanted to put it into other countries across Europe and other things, but it's been in Japan now for about 8 years or 10 years, and they've got RUDY Japan. They changed the color system to be cherry blossom, and they're using it there. And excitedly, through the consortium, we're now working with China. So we're meeting with Mr. Zhu from China to see how it would work there. So that's the timeline from 2013 to where we are now. So we did lots of stuff beginning. In 2018, all rare diseases went in because loads of my colleagues said, why can't we have a RUDY for muscle disorders or mitochondrial disorders? So we put all diseases in. We spent about 4 years doing myeloma research, a very rare bone disease, and they wanted to use RUDY, and that's why we've got over nearly 1,000 myeloma adults in there. Melanie's here. She's going to be talking. She came to work for us for a year. I don't know, where is Melanie? There you are. You're going to about her stuff in FD pain, and we're really grateful for Kiran. They've now they've invested a huge amount into RUDY. We're now going to measure the effect of burosumab in adults with XLH with a 3-year fully funded clinical fellowship, which is amazing. So what have we done? Where are we? We've got 4,000 patients in RUDY, but how many FD? So 191 registered with an FD-related diagnosis, and this is their breakdown. These are the number that also said they had Mazabrowd. Interesting, Natasha's discussion. What is Mazabrowd's? So some of them said they had fibrous dysplasia. They all said they had fibrous dysplasia and Mazabrowd's, apart from one person who just said they had Mazabrowd's. So it's kind of, you get the feel for that. But we have an FD page, and this is one we really use because you have to fill it in. And so this is the breakdown of the number of people we have who've completed the FD page where we've got their diagnosis. These are the numbers reporting a scan, and I really don't want people with FD to be diagnosed with a biopsy, but still super common. And that we really need to work on that, even in craniofacial. We'd expect it for a few people, but for polyostotic, you shouldn't really need a biopsy. It should be obvious on the imaging. So what have we done over the years? So this is I didn't know how to present what we did. So EQ5D is the questionnaire our health system uses, okay? So we have 541 EQ5D questionnaires filled in by about 84 patients. But because we've been running for so long, there are some amazing patients. So 11 years data with 11 years worth of EQ5D coverage in 20 patients with FD-MAS. That's amazing. So we often do it cross-sectionally, but we now have years of coverage, so we can look at trajectories of aging and all these other things. So that's a really exciting area we haven't really looked into. So these are the other questionnaires. So there's a number of FD-MAS respondents and the number of questionnaires we have. And we really have only scratched the surface. We've set it up. This is all data that is available for other researchers to access. So FD publications, so we did a really early one. We had to publish something. So a medical student published something on quality of life on OI, FD, and XLH. And so you can see who's affected moderately or severely. But you can see that actually quite a few people at that time said they're all right. And that was very interesting. Not everyone with a rare bone disease is in really low quality of life. A lot of people are living very healthy lives, but because we work with health economists, you can do some fancy maths, and then you can go back to the NHS and say, well, if I could improve the quality of life by, say, 30%, this is how much it means to the NHS. So we're starting to show the value of changing quality of life scores in rare diseases. And this is the paper we did. It took us ages with Alison and Mike, with Tiana Spencer. It's a very, very smart study. We combined RUDY with the FD-MAS consortium, and we came up with the interesting observation that there's too much neuropathic-like pain in FD, which has led to other studies. And then another medical student, you can see there's a theme here. We get our medical students interested in research by giving them established data. They looked at how people got diagnosed, who they saw, and what predicted longer diagnostic journey. Unfortunately, it's still women. We still live in a very inequitable healthcare system, so women had a longer time to diagnosis, and also, as you'd expect, if they were older at first symptom, they had a longer time to diagnosis. But the specialist you see is really important, because we need to go back to the specialist and say, look, you're seeing these patients. They could have FD. You need to send them to a centre so they can get diagnosed. Okay, so lessons learned and what we still need to figure out. So I'm going to spend a bit more time. I rushed through everything because it's all published, so what's new? So first of all, diagnosis verification. So you could go on now and log into RUDY and say you've got anything. Okay, we have no way of verifying it. We just trust that you do it. Fortunately, not many people have done that because the results sort of make sense. We have put layers of diagnostic verification in. So they tell us who their consultant is, and when we do a paper on a big thing, we'll often write to 10% of the patient's consultants to say, can you just confirm the diagnosis, because we have that permission. About 20% of medics respond. Most consultants are really busy. What do they want to do? I've got another letter, I don't want to send you anything. The other thing that we've introduced that we haven't really pushed that hard, but if you're a patient in the RUDY study, we have ethics for you to take a picture of your clinic letter and email it to us. And then we can look at the letter and say, yep, that's your name, and in the letter it says fibrous dysplasia, so we do that. What we really want to do is to link into routine healthcare records, but we tried for 4 years to do the paperwork for that, and the data protection issues, even though we have full consent, were just was too much. So I think with any online study with RUDY, the weakness is the diagnostic verification, and it's still something we're working on. Another issue is representative. So who is the RUDY participant? So if you go to an expert centre, you're going to see severe patients. So if you go to Mike's centre or Alison's centre now, you're going to see super severe patients. You're not going to see someone with FD in their tibia who hasn't got much symptoms. Or you can see people who are super severe and have got the resources to go to the NIH. So there are sort of barriers. If you recruit from online, you have different barriers. Clearly, access to healthcare isn't a barrier because you can just do it from your phone. You don't need to be in the hospital to be recruited, but you need to find out about it, and that's why we push it through the patient societies. The biggest thing is digital literacy. It's less of a problem now than it was, but we still have in our older cohorts some digital literacy and digital hesitancy. People are still very suspicious of online groups, and there's a lot of work we need to do as a community to say this is a trusted website, it's okay, we're not going to use your information to insurance companies. That was the biggest thing that came out of our patient engagement. Can you put on there that you will not sell our information to insurance companies or anything else? And we couldn't because it wasn't, our ethics committee wouldn't let us do that, but it's clearly in our literature. The other thing is health literacy. People with living with rare bone diseases and other rare diseases have had this all their life. They're often speaking generally. Some people are sick and tired of being told they're special and all of this. They just want to get on with their life and actually just live it as much as they can. So if they're too ill, they've got so many appointments, so much to do, and they're working full time, they just don't have the time to participate. But in some of our work, we've shown actually they're too well to participate. They don't want to be reminded they've got the rare disease. All they want to do is get on with their life. And why is this study asking me to fill in loads of questionnaires for half an hour that might make me feel a little bit more disabled or that the disease is really bad? And this is a really important reason why I think lots of our responses are different. And that's why what we find in RUDY is very different from what you find from hospital studies or expert-centered studies, because we have a different slice of the rare disease population. And all the while, we've been working with our animators and our patient group and our programmers to make sure the effort of taking part is way less than the value you get straight away. We found if you say the value is, oh, this will improve research, we might find a cure, we'll get treatment, that's fine. But what people really wanted is, how can I benefit now from taking part? And we do that by giving them all of their data back. So if you want to see if your sleep is normal or abnormal, you can fill in the sleep questionnaire. None of our questionnaires are mandatory, and we've really worked on that value for the participant. So with those lessons learned, where do you go from here? So clearly we want to do more about improving the sort of barriers. So linkage to routine healthcare records. It is quite expensive to do because you have to register, and the paperwork is on another level. So we thought paperwork for ethics approval was okay. Paperwork to link patients' consented data, well, given you consent, to routine data is actually something the NHS has really no pathway to do. There was a pathway, but with the recent government work, they've just decommissioned it, so we don't know what to do there. And then ongoing work for value for participation. We did a PhD, looked at this in RUDY, and did all the work. So we had a focus group, we worked with participants, what do you want to do? We made all the changes to RUDY they wanted, all this stuff. It made absolutely no difference to participation because we were talking to people who are already in RUDY. And it's really hard to find people who aren't in RUDY because by definition, we don't know who they are. So I think that is another major barrier, how we improve participation. And I think that the real fear for us as clinicians is what Alison did with that amazing, really nice roadblock picture. So it is amazing. There are so many new treatments available for FD. But for it to make a difference to us as clinicians and you as people living with FD, it's got to be approved by the NHS because we don't have a private healthcare system in the NHS, and long may that live. And the NHS does two things, and often people focus on the thing on the left, but not the thing on the right. So what they'll do is they'll look at the cost, and they'll look at the benefit, and they'll compare it to what you're doing now. And if it's more expensive and actually makes patients worse, you don't do it. Okay? And you might think, oh, that's really crazy. Why would anyone do that? Well, Stuart Ralston just presented the results for osteogenesis imperfecta and showed that the use of osteoporosis treatments in osteogenesis imperfecta have no benefit. Okay, so there you're doing cost and there's no benefit. So we've got a red box in rare diseases already. What you really want is something in the green, where it's less expensive and you have benefit. And we do have treatments that can do that. Where we will end up, it will be way more expensive, but it will have more benefit. And that's where you get the arguments about, is the benefit worth it? And we use different metrics for doing that. But to get there, we need to know what the benefit is. So we had the discussion today. Is it about bone? Is it about mobility? Is it about pain? What is it the treatment will achieve that will bring benefit to society? And to do that, I know the question they'll ask us, how much does FDMS cost the NHS? And we have no idea. We have no idea. We have some idea about patient quality of life, but we have very difficult NHS costs because the coding is not very good. We have no idea of the social care costs. And because every economy is now struggling with productivity, so how do you get more people working to support the older people like Mike, who are going to be retired, we have to pay his pension. So how do we support them, or Bob? So everyone wants to increase productivity, and the productivity is direct. We know maybe a little bit about that. We know nothing about the indirect carer costs. So if your child has FD or you have FD, how much does it affect the family's tax revenue? That's what it comes down to. And without that data, we won't know what to do. And then who is the target population? Is it everyone with even this much FD in their finger? Or is it specific groups? We talked about phosphate levels. So who's the target population? We'll need starting and stopping rules. So when do you start treatment and when might you want to stop it? And then also how you would implement it. So for the first bit, how much does FDMAS cost the NHS? We've already put in to the questionnaire list, we have healthcare usage, which is 8 pages long. And this is a real struggle. To get the data the NHS needs is really hard work because we can't get it anywhere else. We have something called VOLP. It's the Value of Lost Productivity questionnaire. It is the most boring questionnaire in the world. But what it does, it says, okay, where are you at now? Are you working? Are you not working? If you're working, are you working full-time or part-time? What's stopping you working better? Are you taking time off work? Are you on benefits? Are you on all these things? And that will give us a productivity data. And then we have the caregiver. So a lot of people don't think they're carers. But if I say, do you provide any emotional, physical, financial, or mobility support for anyone with FDMAS? They go, well, of course I do. You are now a carer. And actually everyone in this room before they pass away will be a carer because we all have to look after someone at some point. So we're all going to be carers. So we all have to fill in this form. And it's been really good working with the FDSS UK at the back to help us get there. Now, the other thing you have to work on is implementation. And Rudy's doing a little bit of this. So we've set up something called a Rare Disease Collaborative Network. And I'm really sorry I wasn't here yesterday. But we now have a mechanism where anyone in the UK, and we have centres in Northern Ireland, Scotland, Wales, and in the UK, if they have a question about a patient and they're an adult, we have a network where we can meet up and you can discuss the patient. So I work with the southern one, which covers a wide area of London, and they meet monthly. The Midlands is every quarter, as is East Anglia, and the Northeast is trying to get monthly. They're doing it. But the vision is, it doesn't matter where you are. If you're not happy, we have a leaflet patients can give their doctor and say, can you discuss my case on this MDT? Obviously, the clinician then has to do it, but often the clinician will feel really weird not doing it because the clinicians love it. They're completely unfunded, but because we fix their questions, they really like coming to it. It's a really good event for trainees. And finally, we want to use RUDY to really characterize the FD population in the UK. So if you do have to do another study of a new treatment or whatever, the UK is a very attractive area. We have all the centres linked up. They're all research active because they're in RUDY anyway, and we can rapidly recruit if you need men, if you need women, if you need blood tests, we can even do that. With RUDY, we can actually take your blood. We post, I've run out of time, we post you a box with blood tubes in. You take it to your GP. The GP does the blood test. You post it back, and the GP invoices us. So that's the team. That's my mentor, Cyrus. Shout out to everyone, especially FDSS Support Society, and there's my summary. Thank you very much.